Thank you very much, Alicia, and thank you, Pamela and Jürgen, for inviting me here. And it's such a pleasure to be in this great university, which keeps mental health as a priority, and we have a promise from the president that it will be even more of a priority, which is very good. The work I present is the work of 28 commissioners over about 3 years' time. And you have seen and heard Pamela and Jürgen, and now you're going to hear me, but there is another commissioner here, Janice Cooper. Where are you? Can you stand up? So this work started when the editor-in-chief of the Lancet, Richard Houghton, invited some of us to really create a piece that will lead to better understanding and, as your president said, call for action, which is both that we are trying to do. And I'll show you in the next 25 minutes or so. Tell me when my time is going to be up. Some of the highlights of this. This is a 25,000 word piece. So attempt to read it when you have time. But there is an executive summary which you can read in 15 minutes. So there are both the versions available. And so here is a picture of the cover. And here is what we think it should be doing. Our minds, our future, our humanity. And we see this as an instrument for change. Change amongst policymakers, change amongst healthcare providers, change amongst all of you. We see this as an instrument for change for this. And so I'm delighted to present some of the findings of this. If I get too boring, you always have the drum beats to hear too. So you're in good shape. The outline of presentation is that first I describe the challenge, and I will go through very quickly because I think some of the things have been already mentioned by Pamela, by Chris, and so I'll go very quickly. Then I'll describe the reframing of mental health, which is the understanding part, and then a collective response, which is the action part. So let's go back a little bit in the history, which already has been talked about to some extent. There was a report in 1995, which I believe was the beginning of what we call the global mental health. It was titled as World Mental Health, came from Harvard. And then there was this World Health Report 2001, which Chris Murray referred to. I was very fortunate to have contributed to this report, which really put mental health on the agenda of policymakers. Before that, it was not really there. But then there have been many other reports. One of them was Lancet 2007 series of articles. And then again, that has been shown by Pamela, a piece which was about the global challenges around mental health. And then what has not been referred to is the last piece here, which is the Mental Health Action Plan, which I again had the privilege of helping from WHO. This is a document that was signed by 194 ministers of health in 2013 as an agreement as to what needs to be done on the public mental health side, which is the highest level mental health has ever reached in the policy making. But these are just contributing to the building up of the momentum for global mental health, which was extremely well helped by the Sustainable Development Goal. And we all are aware that the third goal is about health, and also mental health and well-being is part of that. But what I really want to put forward is that the Sustainable Development Goals need to be taken in its entirety. That means each of the goals can contribute to other goals. And this is precisely what the message is from the Lancet Commission, that we should not take it as a health issue confined to the goal number 3, but take it as a development agenda which encompasses many other sustainable development goals. And if you read through the big report, there is a table where it describes how mental health interacts with the other goals. And that is something which we are very proud to have created for the first time. Mental health in the SDG is included explicitly within the goal 3 as promotion of mental health and well-being, but also there is a sub-goal on prevention and treatment of substance abuse, and it is encompassed within the universal health coverage. The universal health coverage will not be universal, will not be completely covering the health area if it ignores mental health. So that's one of the recommendations from that. Let's go on, which I'll not spend time on because Chris has already spoken about the global burden of disease. What is worth highlighting is that in all regions of the world, the burden has been increasing. It's not only confined to some regions, in all regions it has been increasing. This chart is taken directly from the report that has been prepared on the global burden of disease. And the big message is that the burden of mental and substance use disorders increased by nearly 50%. Imagine 50% in the past 25 years. And these disorders are now accounting for 1 in every 10 years of lost health globally. This is really a big message, which is still an underestimate. Chris has gone from here just now, but I did have a short chat with him a couple of minutes back to say that we need to actually improve the methodology for calculating the burden of disease because it's ignoring a very large amount of burden. The calculations show that the burden is high, but actually it's much higher than that because it ignores a lot of mortality, it ignores a lot of comorbidity, and it ignores a lot of mental disorders and mental health as a risk factor for other conditions, including cardiovascular illness and other things. So there is still scope for making it more accurate and better. But let's look at the age distribution of the burden. And you will see here 2 things. One, that in the early ages, there is a large amount of burden. And then the burden increases around the older age groups. And this is very important because the burden, if it starts early in life, it affects the whole life, as Jürgen said earlier. And this is one of the reasons why the figures are so high. And so it's mental disorders are beginning at very early age, and it's involving people who are in the prime of their life, looking forward to contributing to society and economically, socially, and not able to do that because of several mental disorders. And that is the tragedy of mental disorders in a way. Again, they increase, in fact, neuropsychiatric disorders increase around the late periods. And that again accounts for a very large amount of burden. And we do know that as the societies become more aging, this burden is going to increase because we'll have more depression, we'll have more dementia, and this burden is certainly likely to very much increase. Self-harm is the third rose in this. And again, you see that it is much higher during the earlier age groups. A lot of young people are killing themselves, and it actually reflects in a way on the society that we are offering to them. They decide to kill themselves rather than to live, which is a very sad reflection of the times that we are living through. Suicide is a leading cause of death amongst young people. This is just one of the reports saying that it is the highest cause for death amongst married women, in fact, all women in India and many other countries. And again, another statistic to say, which again has been mentioned earlier, that a very large number of people are dying because of drug overdose in a few countries. But still, this is again something that is not counted, because these deaths are not being counted as induced by drug use. They're counted as to what killed them actually, which in some cases could be something very different. Let's move on a little bit from the mortality and morbidity to the social determinants of mental health. And we do know that the world is experiencing a large amount of violence, which has serious consequences on the mental health of people. There are people who are affected by conflicts and violence and sometimes natural disasters, a very large number of them. There are people who are affected by chronic diseases like HIV and other chronic diseases, and also increasing inequality in society, also in US, which is responsible for a large amount of distress and in some cases frank mental disorders. We do know that poor people in poor countries as well as poor people in rich countries have a higher incidence of mental disorders. And if poverty is increasing, although we do know that absolute poverty is decreasing all over the world, but if relative poverty is increasing, that's another risk factor for more mental disorders. So there is a large amount of social determinants which give rise to mental disorders and other mental health problems. And unfortunately, the world is seeing an increase in many of these social determinants. And we also do know that there is a major economic burden in terms of time. Many millions of years of work lost simply because of anxiety and depression, leave aside other mental disorders, and a large amount of economic loss because of these conditions, which is not in millions or billions of dollars, it's in trillions of dollars. My mind cannot even fathom so many zeros. And this is what the kind of loss that we have because of this, and it's largely unrecognized and largely uncared for. The question is not whether we can afford to look after mental health of people. The question is, can we afford not to do that actually? However, in spite of all of these figures, the expenditure on mental health care is actually very small. Here, these bars are years of life lived with disability. All of that is work by Chris Murray. And here is the amount of budget out of the health budgets which countries spend on mental health. And you can see the big difference. But what I do want you to notice is that this difference is not only for low and middle income countries, it's also for high income countries. So the gap is global. And that is what the real tragedy is. In fact, as we say, when it comes to mental health, all countries are developing countries. And that is really exemplified by this chart, which shows that we are all ignoring mental health and not investing enough in doing that. Take development assistance, and this has again been referred to earlier, but we have a large amount of money which has gone into several of the conditions, very much warranted, very much needed. But when it comes to non-communicable diseases and as well as mental and substance use disorders, you will expect me to click again to show these bars. There is no click. This is what it is like. On this scale, you can't even count it. It's so small. It's less than 1%. So that is really what our message is to the policymakers, that you need to invest more out of the national budgets, but also out of the development aid money that is going across in the world. The consequences of all of this is that we ignore people with mental disorders. Minimally effective treatment is available for a very small minority of people who live with these conditions. This is the situation in low, middle, and high-income countries. So you would imagine that less than 22% of people with major depressive disorders, even in high-income countries, are receiving the kind of care that they should. And this is something that should, in this year and this era, should be completely unacceptable. Together with that, there is the human rights issue. Mental health, people with mental health conditions have been stigmatized and their rights have been, frankly, abused and disregarded in almost all countries for a very long time. And this continues to this date. Some of these pictures are from low and middle income countries, but not only from that. But one of the pictures is from a high income country in a prison setting, where again, people are incarcerated for indefinite period because of no fault of theirs, just because they have a severe mental disorder. So there is need for reframing mental health. The world has simply not responded to the evidence, and all countries, as I said, are developing. We also need to go beyond addressing the treatment gap, which we talked about in 2007, that one of the big priorities in the area of mental health is to actually provide treatment for people who suffer from mental disorders. But the evidence that is available now makes us believe that we need to be much more comprehensive. We need to think much more about mental health rather than just about mental disorders. And that is the reframing that we are talking about here. We put forward in the commission the dimensional approach to mental health. it is no longer possible and no longer helpful to divide people, like, for example, all of us in this room, into two categories. One, people who have mental disorders, and others who don't. It is simply not very helpful. All of us are somewhere on this dimension of having either very good or sometimes very poor mental health. And we can all do something to improve our mental health. And that's what we recommend in the commission, that there is something called a positive mental health, and all of us can do some things to improve our mental health and well-being. In some cases, we might be at a risk for mental ill health, and we can decrease the risk by prevention. Some of us may have a mental disorder, and we can do something about getting that treated, achieving a remission, and hopefully achieving a recovery. So we all can do something about even our own mental health, leave aside the mental health of people who are within our family or colleagues. So it touches and affects all of us, and it should. So in effect, mental health is something that should be a concern for all of us. Not only because there is high prevalence of mental disorder, but because all of us need to be concerned about our own mental health and try to improve upon that. And there are enough interventions for all of these things that we're talking about. We propose a convergent understanding of mental health. We rely upon the neurosciences to give us some elements of the picture that we're trying to produce. For example, there is the neuroplasticity, which is very high in the early ages and decreases. Plasticity means that the brain reacts to the social and the physical environment that the brain lives in. And this capacity of the human being and human brain continues at a very high level in the beginning, but does come down as we age. There is also the neuro phenomenon of pruning and differential maturation, which comes at a particular age and goes down very quickly. And then there is the last phenomenon of senescence, which people at my age are having. And these three things combined give rise to the biological substrate of the brain, which is eventually responsible for mental health condition. So there are critical periods, and obviously there is the environmental influences. But it's very interesting to note that if you calculate the prevalence of mental disorders and put it under this chart, we see that during the critical periods, there is a high incidence and prevalence of mental disorders in the early life as well as in the late life. So brain functioning and the way brain matures has a lot to do with these mental disorders and conditions. And obviously the environmental factors play a very large role in the beginning as well as all throughout. So this is in one slide a lot of material that the commissioners have gone through and suggested that this should be the basis for a convergent understanding of mental health. And this translates directly into research questions, which need to be answered by a variety of specialists from different areas, and that is happening. We also advocate for a rights-based perspective, the rights of people with mental disorders to be protected, the right to receive care. We talk a lot about, in some countries, about right to refuse treatment, but the discourse in most of the low and middle income countries is the right to receive treatment, which is perhaps a better right to talk about, and the right to dignity and freedom. Also, the pioneering aspect of mental health care. We have some lessons to teach to other healthcare areas. For example, reconfiguring care to hospitals and communities, involving patients and families, and so on. So these are things that mental health actually does in a way better than in many of the other health areas. There are innovations in care because there is evidence for all of the things that we are presenting. Psychosocial interventions by non-specialist providers, digital tools, balanced care models, and community engagement to increase demand and accountability. In fact, in WHO, we presented a pyramid for care. At the bottom is self-care and informal community care, which should be available to everybody and cost very little. And at the top, there is the specialist care, which should be available to only a few people and obviously costs very high. In most cases, the pyramid is small and it's also lying upside down. So we put more emphasis on specialist care and not enough on the other kinds of care, which should actually be available much more. I'll skip this slide, but if you're interested, there are very specific interventions for low, middle, as well as high income settings. And here I want to point out that these are not low, middle, and high income countries. These are settings, because there are low income settings in high income countries and vice versa. So coming to the recommendations, our first recommendation is to reframe mental health, which I have described in detail, but I'll spend just the last 3 minutes on some of the other recommendations, which are very stark, which are all black and white, no colors here. We want to just present the recommendations as they are. Reframe mental health as a global public good, because it's a universal human quality, it's indivisible part of health. It's important to all people in all countries, especially relevant for young people, and crucial contributor to human capital. In fact, the World Bank is talking now so much about human capital as a counterpart to the GDP, which they've relied upon for a very long time, and mental health has a lot to contribute to the human capital. Mental health, an essential component of universal health coverage. Every country must do that. I know that there is a lot of discussion in US about universal health coverage. Not many people accept that as a principle for healthcare, but they should. And this is a very clear recommendation. There should be universal health coverage, and mental health should be part of that. Protection of mental health by action on social determinants must be there. And you will immediately recognize that most of these actions are outside the health departments and ministries, and that's how it should be. That all the sectors need to work together to see to it that we create an environment where positive mental health could be encouraged and protected. Strengthen public engagement, very important. Implement evidence-based interventions to reduce stigma and discrimination, and there are many. And also engage civil society. People like Alicia London, who just now introduced me, we need her and other people to be actively engaged. Mental health is too important to be left to the specialists. We need them. Make more and better investments in mental health. This is a message again for all countries. We need to increase national financing, at least 5% of the health budget for low and middle income countries, and at least 10% of the budget in high income countries. But we also need to see to it that the resources are used efficiently and effectively. And again, USA is perhaps not one of the countries that is using resources, very high amount of resources, in the most effective and efficient manner. So there is a lot of ground to be covered here. And as I said earlier, spend more development aid on mental health. A little bit about the research. I'm running out of time. So based on the grand challenges, we recommend a priority agenda for research, which again uses the Convergent model. The research from neurosciences needs to come together with the social sciences to have a good impact on how we can do that. And lastly, monitoring and accountability. If we put more resources, we need to be accountable for that, and we need an international as well as national monitoring and accountability mechanism to be done. So in a sense, we advocate for going from no health without mental health to no sustainable development without mental health. I will just project this slide, which is the number of people who contributed to this effort. And Yogan Unut sir, your family name starts from U, so you always come in the end. But thank you very much for a contribution, and thank you all of you for listening to me.